Dr. Laura Ormesher, she's a NHR academic clinical lecturer and in the section of gynecology in Manchester and specializing in hypertension disorders and pregnancy, and is going to talk about postnatal hypertension management, where we are now and how do we move forward. Thank you very much.
Thank you so much. And yeah, thanks for giving me the opportunity to talk about this today. Hopefully everyone can see my slides. Please shout out if not. So yeah, postnatal hypertension management. Sorry, all okay? Okay.
Yes.
Thank you. Where are we now and how do we move forward? So I don't think I need to preach the converted, but we'll just briefly touch on why the postnatal period and postnatal hypertension management is so important. So firstly, just thinking about it, what are the aims of postnatal care? So essentially it's to support the mother and baby and really to reduce immediate risk. And this graph from Bray's report really reminds us how lucky we are in the UK in terms of how rare pre-eclampsia related maternal deaths are, but also to remind ourselves that the majority of these deaths occur postpartum. So we shouldn't be sort of feeling all sort of reassured now that the baby's born, our job is done. We need to be sort of vigilant at this time. So what we need to do is reduce the immediate risk to mother and baby, obviously, and to safely discharge them into the community. And then there's also a role of postnatal care to improve a woman's long-term risk, which we'll talk about a little bit more. So I'm sure you're all familiar with the concept of pregnancy as a stress test for a number of different systems, but in particular today, talking about the cardiovascular system. So you've got the increasing metabolic demands of the growing fetus, and the maternal cardiovascular system essentially has to adapt. So it increases its cardiac output by about 45%. And this is a bit like weight training, essentially. The heart has to bulk up. So the left ventricular mass increases. And outside of pregnancy, over a decade, it may increase by about 21%. In a healthy pregnancy, it increases the same amount over a 9-month period. And in a hypertensive pregnancy, it increases by a stonking 95%. Then mum has the baby. And in the postnatal period, there's this absolute requirement to return to the pre-pregnancy status. So you get this requirement for rapid de-remodeling, reversal of that thickening of the heart muscle back to what it was before the pregnancy. And the reality is this is not always successful. So we know that hypertensive disorders of pregnancy, and in particular pre-eclampsia, are associated with problems beyond the pregnancy period. So into the postnatal period, you get persistent adverse remodeling, so thickening of the heart muscle, diastolic dysfunction, so stiffening of the heart, and hypertension that's persisting beyond that typical 12-week period, which we deem to be related to the pregnancy. And then we know that these women are at increased risk of cardiovascular disease, and things like heart attacks, strokes, heart failure, and a number of these things have been talked about already. And what we need to remind ourselves is, although these are young women and their absolute cardiovascular risk scores are relatively low compared to if you're looking at sort of 70, 80-year-olds, these conditions occur earlier and with a higher fatality in these women. Now, what we really, really need to recognize is pregnancy as an opportunity. And this was touched on in the Poppy talk. 45%, so nearly half of pregnancies in the UK were unplanned. So it really limits what we can do pre-conception. And for many women, pregnancy is their first adult engagement with the healthcare system. So therefore, pregnancy, the postnatal period, this is our moment. This is our opportunity to identify people at risk, to screen for risks, and to provide primary prevention where possible, recognizing that we've just said pre-eclampsia and adverse pregnancy outcomes are associated with long-term health problems. So just knowing what happened in that pregnancy is enough to sort of identify someone at increased risk. So I feel very strongly, and hopefully lots of other people in this virtual room do too, that we have a duty as maternity healthcare providers to acknowledge this, to educate women, and to optimize their cardiovascular health. Now, in pregnancy, it's tricky, isn't it? Not all drugs are safe in pregnancy. We're balancing the benefits and risks to mum and baby. Postpartum period, by no means is it straightforward. It's chaotic. There's potentially lots going on. But these women are motivated. They're motivated for their future pregnancies. They're motivated for their long-term health. And there is evidence to suggest that if we lower blood pressure well in the postnatal period, it can lead to lasting improvement in blood pressure and hypertension risk longer term. So in this way, early postnatal blood pressure optimization could have significant implications to long-term cardiovascular health. So that's a quick reason for why we care. The next question is, where are we now? So I'm going to touch on some local data. So this is a retrospective cohort study we completed in Manchester. It's 15,884 blood pressure readings from 570 women. These women were identified across 3 maternity sites, 1 trust, 3 sites. May to November, and they were identified through the electronic healthcare record systems as having been prescribed antihypertensives. So that's how they were sort of identified as having had hypertensive disorders of pregnancy. So let's just quickly touch on what the burden of disease is. Essentially, rather depressingly, 29% of these women bounce back to triage in the first 6 weeks postpartum. And 39% of them have severe hypertension. And when we looked at those presentations to triage, the majority of these were due to hypertension, unsurprisingly. And a quarter of them then ended up being admitted to a postnatal ward or the labour ward. And as many as 10% of this cohort had 2 or more presentations to triage. So huge burden to the women, their families, and the healthcare system. Now, this graph is showing what the blood pressure trajectories were in this cohort. And what we're seeing, the green line there, the average, the median day of discharge was day 3, and the peak blood pressure across the cohort was day 5. So what we're doing is we are discharging women home early, which may be seen as a good thing, but we're discharging them home before they reach their peak blood pressure. So we're discharging them home potentially falsely reassured by what their blood pressure is and will be, not recognizing it's going to creep up in the community over the coming days. So what are we doing with prescribing practices? So all of these women were identified for having been prescribed antihypertensives, likely in the antenatal period, but actually as many as 38% were discharged home without anything. So though their medication was stopped post-delivery or not continued post-delivery. And when we look at what women were prescribed, the most common prescribed regime was amlodipine, so 39% of the cohort. But actually, 3 sites, 1 trust, 28 different regimes were used in the first 14 days. And there was so many changes in that first week. So on average, women had at least had 2 changes of their antihypertensive regimens in that first week. And of those on 1 antihypertensive, 57% were prescribed once daily regime. So that means 43% of women who could be given a very simple 1 tablet a day were likely prescribed BD, more likely TDS or even QDS, sometimes labetalol regimes, which is no small task for someone who's managing NICU trips or new motherhood at home. So the next question is, we talked about what the problem is or why we care, what we're currently doing, what should we be doing? So this is what NICE says. NICE says treat, so start antihypertensives postpartum if blood pressure is over 150 over 100. And that's really to avoid the complications of severe hypertension in terms of, having a woman having a stroke. But I think reflecting on that previous slide, it's worth considering the physiological postnatal trajectory. If we are looking at a blood pressure of a woman on day 1, we need to be having a lower threshold for starting treatment, recognizing that it's going to be creeping up over those next few days when they're at home, and recognizing we don't want them to bounce back with that high blood pressure. And I think we also need to be considering the long-term health implications, as it is likely that driving your blood pressure lower than that and intervening at an earlier stage is better for a woman's long-term health. Once daily regimes are recommended, which to optimize compliance, which is very sensible. And currently NICE recommends enalapril as the first line. And this isn't based on postnatal specific evidence, but really in line with adult hypertension guidelines. So the next question is, what should we be doing in terms of evidence from the literature? So home blood pressure monitoring. So the Oxford group, and I think we're hearing from Jamie Kitt later. So Jamie Kitt, Rich McManus and Paul Leeson have done some fantastic work looking at physician-assisted home blood pressure monitoring, so in the postnatal period. So not giving a blood pressure monitor and saying off you go, but sort of supporting a woman to up titrate, down titrate their medication based on home blood pressure monitoring. And what they showed was that blood pressure was lowered compared to standard care, which is brilliant. But what was really exciting is this improved blood pressure control persisted well beyond the intervention period, beyond the time that they were taking antihypertensives, and as far along the line as sort of 3 or more years later. And they did the imaging sub-study, which showed that they've got this improved de-remodeling, this reversal of the adverse remodeling seen in pre-eclampsia. And this may reflect a long-lasting effect of stricter early postnatal blood pressure control. But I think it highlights the fact that early, tighter blood pressure control could improve that correction in that cardiac remodeling, and therefore could lead to sustained improvement in blood pressure. So home blood pressure monitoring, definitely something we should be thinking about. And I look forward to seeing what SNAP2 shows us over the coming years. And next, in terms of antihypertensive choice, the short answer is we don't really know. There's not enough evidence. So there was a there was a multi-center retrospective cohort study done in the US, which showed that prescribing anything, so prescribing antihypertensives compared to not prescribing antihypertensives to women with hypertension in pregnancy, reduced their readmission rate. And we know from a number of studies that on average, more than a quarter of women go home with hypertensive disorders of pregnancy without any antihypertensive treatment. And that's in line with the recent data I've just shared. They did a small single center RCT in the US comparing enalapril and nifedipine. And what they found was there's no difference in hospital readmissions. But with enalapril, they were more likely to need a second agent, which isn't entirely surprising because the way that we typically titrate enalapril up is we start at a lower dose and gradually titrate it up, monitoring renal function, etc. So you're probably at a subtherapeutic antihypertensive level to start with. But interestingly, they found that they were on treatment for less long, those who were on enalapril, which makes you question whether that's anything to do with improving the reversal of the remodeling or something and sort of resetting blood pressure earlier, or whether it's just a numbers thing. But definitely more research is needed in this area. In terms of evidence from our retrospective cohort study, to hint at what we think we should be doing, in line with what I've just shared, despite having higher starting blood pressure, the women who went home with medication, their blood pressure dropped quicker than those who went home with nothing. And that's the graph underneath. You can see that the red is the women discharged on medication. So they started off with higher levels and then they cross over and end up with lower levels. And calcium channel blockers, amlodipine and nifedipine appear to be associated with a steeper decline in blood pressure. Got to recognize the limitations of this study. It's retrospective, it's routine data. This is not a prospective or randomized controlled trial or anything. But interestingly, in line with what the US study showed, women who were discharged with any antihypertensive were 33% less likely to re-present to maternity triage. And women prescribed amlodipine were 42% less likely. They appear to be the least likely to re-present. So even if we can't quite believe the longer term impact, but I really hope we do believe that, there are really good improvements in short-term care that we can provide by just simply treating blood pressure. So how do we move forward? And I think there's a number of ways we can move forward, thinking about education, proactive prescribing, continuity of care, and then about the sort of potential for postnatal clinics. So touching on in education and empowering women, I think it's really important to remember that, yes, we've got all of this epidemiological data to say these women are at increased risk, but how we package that information helpfully. When a woman's just had a complicated pregnancy, they may have experienced baby loss, and then we're telling them they're at an increased risk of a heart attack. So it's sort of reframing that risk counselling and empowering women with actionable advice. So Pearl Kadiri, the picture on the right, she's one of our postnatal midwives who did a secondment with us, funded by the BRC, and she did some excellent work co-developing some information giving tools with women who've experienced hypertension in pregnancy from a number of different diverse backgrounds. And they wanted infographics, they wanted it to be usable on your mobile phone, essentially. So these are a number. I'm more than happy to share any of these with anyone who's interested at the end. Drop me an email. But this is looking at exercise and not just saying go to the gym and get fit, but also thinking about how that may be able to be fitted into a busy postnatal mother's life. And then thinking about food beyond saying don't eat fatty foods and don't eat salt. How do you replace the flavors that they like with something that's healthy? How do you replace the cooking techniques that they like with something that's healthy? And looking at culturally inclusive recipes. So trying not to reinvent the wheel. BHF, Diabetes UK, NHS Healthier Families have excellent links to various culturally inclusive recipes. So we've included that within our sort of infographics. And then trying to make numbers make sense, because I don't think it's very helpful telling someone that they're 4 times more likely to have hypertension, because what does that mean to them? And I don't think talking about things in 10,000s is also very palatable. So we've tried to sort of reframe that in a way that is comprehensible, and the women seem to like it in this format. The next thing is proactive prescribing. We've just demonstrated that treating hypertension, even if it starts off relatively lower and better controlled in those first few days, is a good thing. So I think we should be really trying to proactively prescribe antihypertensives for women to take home. It reduces their readmission rate risk, and improved early postnatal blood pressure appears to improve long-term blood pressure. And given that we know that hypertension is the leading modifiable risk factor for all-cause mortality, this is a really simple thing that we can do that can have a lasting positive impact on a woman's health. And then I think we need to keep it simple. There's so much research that needs to be done in this area. There's so much that we don't know. But whilst we're awaiting or seeking that definitive evidence for drug superiority, let's just think about that period in a woman's life and keeping it simple for the clinicians involved, and also for the women themselves. So once daily regimes, whether that be amlodipine or whether it be enalapril, factoring in the need to titrate doses up and monitor renal function. And I think we need to be anticipating that day 3 to 6 blood pressure rise, having a lower threshold for treating earlier, knowing that it's going to creep up in the community and we don't want them to bounce back. And also recognizing that these once daily regimes, if we're starting them, there's a delay before they get to steady state. So actually, if the blood pressure is pretty normal, by the time it kicks in and does something is when they would have naturally crept up. So I think we need to worry less about dropping their blood pressure too low. We've really kind of reassured ourselves of the safety of dropping blood pressure in pregnancy. So if anything, we should be even more secure in the postnatal period. In terms of continuity of care, as you know, it's incredibly difficult to achieve this with the current care model, particularly in the postnatal period. And so just again, thinking of things that are simple, like if someone is under an antenatal hypertension team, putting a clear plan in place for their postnatal antihypertensive regimes, or knowing who to contact in your hospital trust or maternal medicine network, and empowering women to monitor their own blood pressure, empowering women to know who to contact and when to contact about titrating their medication. And I think that this is something we should be considering going forwards, and that's work to do this area really about the possibility of prolonging secondary care oversight, given that it's such a nightmare to try and get a GP appointment at this time. And I'm going to very quickly touch on the postnatal hypertension clinic. So we set up Insight a year ago in Manchester. We've had 106 women to date. And the aim is to improve care now, so improve the way that we counsel women and give them advice, do some simple assessments, but also to do some research to improve care for the future. So doing some detailed inter-pregnancy phenotyping, trying to look at the link between their postnatal health and their future health. And very quickly, I'll just explain that we do a number of different tests in this clinic if they take part in the research, looking at their heart, their vessels, their hemodynamics, their metabolic status, and then holistic side of things and mental health as well. And I see them face to face at the 3 to 6 month mark. And then again, we invite them back at 1 to 3 years. And we've got a number of pathways currently in place, but this is very much a working model in terms of the research, but also the clinical service. And I look forward to this developing over time. So I'll just very quickly touch on the results so far. Essentially, we have a very diverse group of women coming through to the clinic, which is really good because we know that these are the women most at risk, women from ethnic minority backgrounds, women from deprived backgrounds. And the good thing is we are getting them back in the postnatal clinic. So half are from ethnic minority backgrounds. The average index of multiple deprivation is 3 in this group. So they're in the lower 30% in terms of deprivation by postcode. Got about 14% of them had high blood pressure prior to 20 weeks of pregnancy, and loads of them do home blood pressure monitoring in the first few weeks. By the time they see us in clinic, very few of them are continuing, and very few of them, less than a quarter, manage to see their GP at 2 weeks. But in terms of what we're finding loads of pathology. So these are women who wouldn't otherwise be picked up by routine services currently, and 39% of women who didn't have hypertension before have persistent or return of hypertension at this clinic appointment. Half of them have abnormal lipids, over a third have proteinuria, and over a third have 10-year cardiovascular risk scores that are more than double what they should be for their age, sex, and ethnicity. So I think we need to recognize these women are high risk now and in the future. We need to educate ourselves, colleagues, women, and ensure that follow-up is in place. We need to target those cardiometabolic risk factors early, and we really, really need to proactively treat hypertension, working together to learn from each other in terms of current pathways, experiences, pitfalls, and current sort of clinic setups that people have. And thanks to everyone who's involved, and thank you very much for listening.
Okay, thank you very much for that very interesting work of that, and a very important work of this continuing potential risks that women have following a pre-eclamptic pregnancy.